Fiona, I just had a question about the Shore fuses. So using them predominantly subcutaneously, but do they work intravenously as well? We don't know, only use them subcut.
Well, in the palliative care setting, we use them just subcutaneously, but I believe they are used intravenously for antibiotic, and haematology use them for different infusional medications.
Yeah, thanks. Jason?
So I thought they were four fantastic talks. Thanks very much to everyone. And Gabby's talk got me academically directed with some of the wonderful research that she presented about the way that they've evaluated their service. And one thing that didn't quite jump out to me, and I'd be really interested to know whether or not you've done this yet, is quality of life assessments. And I imagine, because I saw that you ticked off almost everything else, and I think that it would be a lay down misere, for want of a better term, but it'd be really nice to articulate how much appreciated the service is. And that would also go for both Dave and Fiona's talks as well, and Melissa too. But I was really focused on the first three presenters and see what you thought about doing some quality of life assessments to be able to showcase to your business managers about how appreciated this is by the consumers of the service.
Yeah. Oh, thank you. Yeah, thanks very much. Yes, we are doing formal quality of life evaluation. So as part of the original observational study of just paediatric febrile neutropenia management across Australia, we surveyed patients and their parents. And so that's provided us a good baseline data of what their quality of life was, just sitting in hospital having standard care. And we're replicating the same survey tools in our implementation phase. And we've got some prelim data currently being analysed from the Royal Children's in Melbourne in a pre and post setting. And so that's kind of the quantitative component of the quality of life assessment, but there's also a qualitative component and interviews with families and comments and things that we're working through. But yes, very as important as the cost evaluation.
Well, I think it adds to the whole story. How about you, Fiona?
Yeah, thank you. We're in a sort of data collection phase using some palliative care outcome scales and also some caregiver questionnaires too. But that's I guess a bit more general for our rapid palliative care service, which is supporting those Monash Health patients in the community. But we're definitely interested. We're doing some work looking at trying to define who this HITH rocket drain population is, because I think they are so varied, and looking at are they how many are at the end of life when they're having that intervention and meeting us, and what's the outcome of us meeting people who are much earlier in their cancer journey. But quality of life, very, very important, and often only later thought about and collected. So trying to do that from the start.
And I think for the broader audience, it's studied in the broader HITH space, but in these two subgroups, to have that extra data is really, really important.
I was also interested in what Dave's perspective on this may be, because he did make a comment that maybe some of the carers, their role has changed a little bit because of the extra attention that they're required to give the patients in the home. And so it may be a different approach that's required to be assessing not just the patient, but also the carer as well, and what their perspective is. Dave, do you have any comments about that?
Yeah, look, from my point of view, I always think quality of life data is a very useful thing. But as always with my oncology colleagues, they're always very skeptical of the quality of life data due to its quality itself, in terms of how you record it, when you record it, how the patient fills it in, what's happened to them that day compared to the day before. It can always be all over the place, but I still think it's very useful data. And the carer fatigue one was one that we were really interested in, because we thought, we are shifting a lot of pressure onto loved ones. They are being with them all day. They are thinking, should I call? Should I not call? Do I need to bother the doctor because they're really busy? And we thought it might be quite significant. But in fact, what they said was that it was nice to have my loved one at home and I got to look after them. And that was really, I thought was really good conclusion from that. But I think the other thing is you're just trying to standardize this data, you know, the EORTC, which is what a lot of us use for that, making sure you try and use an internationally recognized one so you can use it to compare against other things. I think that's the important thing. It's very easy to throw together a 10-question survey going, how do you feel 1 to 10 on something? But then you can't compare it to anything. So yeah, definitely trying to use some of the standard ones that exist and make your data fit them rather than making the new ones up. I think it's a good thing.
Dave, while you're there, there was just a question that popped up in the Q&A there around how you convinced your colleagues to send the neutropenic patients home. You did mention it briefly in your talk, but do you want to just restate how you got them over the line?
So I think probably everybody's had experience of this. There are colleagues that come with you willingly. There are colleagues you drag along, and there are colleagues you just isolate. So, you know, those ones you don't bother even trying to get their patients onto the system because they'll always have an opinion about something slightly going wrong, even if it was perfectly reasonable. One of the things I think helped a bit was the fact that we made a deadline of 48 hours in the hospital. Blood cultures all come back, all negative. Patients being, and then what we also did was patient had to be apyrexial as well for 48 hours before they went home. So the argument there is actually, well, some of these other things like the mask score, right, you could switch to oral antibiotics potentially and send them home and finish a course off. You know, there is some argument to that, but doing the IVs was the way forward, and 48 hours, well, no temperatures, nothing growing was the reassuring thing.
There's a nice study in adults. I think it was 850 adult patients with febrile neutropenia, and over 90% of the blood cultures were positive within 24 hours.
Yeah.
So by just providing, I guess, more reassurance to colleagues that 48 is well and truly long enough.
Yeah, and look, what happens with a lot of our autograft patients is on the Friday before the weekend, they are day +8. And they normally start to engraft about day +11, which is the Monday. And you tend to hear these conversations of, oh, well, you know, they're not quite right, and the weekend's coming up, and we better admit them. But also, that's the day they tend to have like a one-off temperature as their neutrophils are coming to life. It's not an infection. And so they tend to get admitted around day 8, be perfectly well over the weekend. And you think on the Monday, oh, we'll send them on IV antibiotics. But by the end of the day on the Monday, they've almost neutrophil recovered. And you sort of go, well, we can stop the antibiotics and just send them home tomorrow. And that tends to be what happens. So we didn't get as many patients I thought we would on the home early on IV antibiotics, because a lot of them they sort of recover beforehand almost.
Can I ask Gabby another question? Gabby, I noticed that in your acknowledgement slide, you had a consumer. And obviously, as part of providing this service, you know, you're always interacting with the consumers of the service. But I assume that you've got someone who's consistently involved in advising on the program. Could you tell us a little bit about what contribution that they've been able to make?
Oh, Cindy's been fantastic. So she is a mum of a child with lymphoma that's in remission and doing really well. And she had a couple of febrile neutropenia admissions during her time when her child was having chemotherapy, and has also been able to develop quite a good network of friends within the hospital of children going through similar things. So in order to find her, we approached our patient liaison officer within the hospital, and they've often got a list of names of people that have put their hand up in advance to be part of these type of things. I think there's a lot of parents or patients that are out there that want to be involved and to inform research. And she's part of our steering group for our national implementation study. She at the meetings every month, advising on the protocol and the patient information. We've just completed a parent survey of the impact of COVID on the implementation, and she was able to distribute that survey through her parent and consumer network that she's got across the country. So they are just so valuable, and I think we've really moved in the way we implement and change practice to having a token consumer, because that's what the book says you have to do, to really having the consumer embedded within the program, and they're just incredibly valuable. And one's probably not enough.
Thank you.
Melissa, with the paediatric patients at home, in terms of either delivery devices or delivery mechanisms, how do you choose in that paediatric setting which way you're going to go?
Yeah, it can be a bit complicated. There's a lot of variables around age and I guess the activity of that particular child, also the medication itself. And as I touched on, some of the devices just aren't compatible with particularly our smallest of patients on the service. So we generally try and avoid using elastomerics with those small catheters, just because of our experience, and use I guess more traditional pumps that we'd see in an inpatient ward, which are on battery, and try and use once daily approaches where possible. Sometimes there is a bit of a creep with extended AMS, and that's definitely a challenge with those children. I've heard it ceftriaxone affectionately called vitamin C at one stage, so trying to balance that. But yeah, there is a bit of consideration around, you know, is this child going to tolerate a continuous infusion device, or do we really need to consider if we've got a once daily option or other kind of treatment modalities? Yeah.
It's tricky.
Yeah.
All right. Well, look, we're a few minutes ahead of schedule, but not by very much. So I'm going to again thank all of our panelists. They're all 4 fantastic presentations and really informative for me and for our audience, no doubt. And I'm going to hand to Jason to close.
Thanks, James. Thanks for your expert chairmanship. It's always a pleasure to watch you operate. You were helped by 4 fantastic speakers. I learned a lot tonight. I'm really grateful for everything that you presented on, and some wonderful lessons. So thanks very much. And finally, well, second last, I'd like to thank the sponsors again for their support of this. You know, it really does make it possible to have the support that you provide us. So thank you very much to MSD, Baxter and Pfizer. And finally, to the participants, thanks very much for the feedback you've given us to help shape the program that we've put together. We are very hopeful that we'll continue this next year along this same theme, because we think that there's a lot of curiosity and desire to learn more about how we can use this approach to delivering healthcare. And so, you know, it's our pleasure to try and link in with all of these fantastic experts like Fiona, Dave, Melissa and Gabby. And let's hope that 2021 is a better year all round and we see more of these kind of fantastic seminars. So thanks very much, everyone. And last but not least, Luminita for all of her management of the whole process. Have a great night, everyone.
Thanks very much.
Good night, everyone.
Thanks, everyone. Good night.
Thank you.